Ladies and gentlemen, a very warm welcome again on the next edition of the webinar series. And today, our guest is Professor Jan Bakker. He has so many affiliations that it's difficult to mention. He's currently in Chile. So thanks very much, Jan, for taking the time and effort for joining us. And as before, this is the SIP of Science webinar organized by Translational Medicine and the Semmelweis University's Department of Anesthesia and Intensive Therapy. And today we have the privilege of one of the greatest perfusion scientists in intensive care and critical care, Jan Bakker, to have us to have him with us here. And those of you who joined us online, you will have, and everybody else will have the chance to watch the lecture and the questions once we prepare the video that will be available on YouTube. So with this short introduction, I hand the stage over to you, Jan, and we're really looking forward to your talk.
Thank you very much for the nice introduction. Before I start, I would like to get your attention to the hemodynamic management and monitoring course that will start in November. It will be a European diploma on this, let's say, area of intensive care medicine. If you're interested, then send me an email. So to start off, how to use lactate in clinical practice. These are my possible conflicts of interest. Basically, to this lecture, it's only Abbott. Abbott UK is working on a continuous lactate monitor for patients. Now, before we start to talk about lactate, it is very important that you understand the metabolism of lactate, because that plays a very important role if you're, let's say, a few hours into your resuscitation, and I will come back to that later on. So there are two types of lactate, two optical isomers. L-lactate, that's what we use in clinical practice. That's being produced by human beings. And we have D-lactate, that's produced by bacteria. We produced D-lactate in our gut. We tried to do a study a long time ago on D-lactate. Very complicated, never worked. The pKa of lactate is very low, meaning basically that lactic acidosis does not exist. Lactic acidosis, because lactate is dissociated almost at every stage. I mean, if your pH is 3.86, you're probably not alive anymore. So lactate is always dissociated from the H+. And the H+ is used in the metabolism of pyruvate. Lactate is also a very important energy source. So if we do not have lactate, especially some of our cells in our brain get into trouble because they rely for their energy source on lactate. So does the heart. And so this lactate shuttle is a very important source of energy for some parts of the body. Now, this is the metabolism to start with. So you burn, you metabolize glucose to pyruvate, and this is under influence of phosphofructokinase. It produces a little bit of ATP, only 2. But this can speed up a lot. And so if you speed up glucose metabolism, you rapidly still produce a lot of ATP. This is the first mechanism we use to generate energy, because the Krebs cycle is rather slow. Now, this is a pH-dependent enzyme. That's why you can have effects on lactate in alkalosis acidosis, especially alkalosis produces increased lactate levels. So if you speed up this process, you will start to produce lactate, because this is a rate-limiting element. what speeds up glucose metabolism, lactate metabolism? Well, for instance, if you give pyruvate, if you add this substrate to a patient or a healthy volunteer in this case, you will start to produce lactate. As you can see here, you increase your pyruvate, you do a pyruvate infusion, lactate increases. This is your pyruvate concentration, this is your lactate. Lactate increases, you stop the pyruvate infusion here, and lactate decreases again. What's interesting to see is as you start producing lactate, you do not get acidosis, just to underscore the previous comment I made. If with something else you increase glucose metabolism, you will have the same effect. You will start to produce a lot of pyruvate, which ultimately lead to lactate production. A clinical example is epinephrine. This is a epinephrine infusion in healthy people, and this is the amount, increasing dose of epinephrine. This is your lactate, and as you can see, lactate goes up if you give more epinephrine. So if you give a bolus of epinephrine during CPR, you should expect lactate to go up by definition. If it doesn't go up, your patient is in real trouble because then metabolism is not okay. So this is the start, and if you increase this, so glycolysis, you will start producing lactate because this enzyme, pyruvate dehydrogenase, is a rate-limiting enzyme, and so this is way slower than this. And so the oxidative phosphorylation, which is much more efficient, I mean, this is 2 versus 36 ATP, so it's much more efficient, but it's also much slower. So that's, let's say, in a nutshell, the main elements of lactate metabolism that play a role in clinical practice. Of course, the metabolism of lactate in and of itself is also an element, but that's not a huge problem, as we showed in studies that we did in septic shock. Lactate metabolism in the liver is almost completely gone in sepsis. And so you produce lactate, but there is no metabolism of lactate, despite the fact that the perfusion of the liver is completely normal. So there's more to it, but this is, let's say, the very basic that you need to know. Now, how did we come to start using lactate? That's Max Hariwal. Max Hariwal, I think, is basically the godfather of critical care. HAL, as he was called in daily practice. HAL was basically in cardiology, cardiogenic shock, resuscitation, stuff like that. He was not so much in sepsis. His institute was basically cardiology and cardiology-related problems. In his annual lecture, in the annual lecture in 1979, he basically said, well, lactic acidosis is a sine qua non of oxygen deficit. So basically what he meant, if you do not have an increased lactate, there is no tissue hypoxia. And basically he said, and that's what has been driving up until now the diagnosis of shock. Even in the next definition of shock that will published hopefully soon, we said lactates are typically increased. It's very difficult to talk about the patient in shock that doesn't have an increased lactate level. So that's where our interest comes from. It's a very powerful denominator, basically, of a very deadly, let's say, context of critically ill patient shock. Now, if you go to the lab, what is shock in the lab, and what's the tissue hypoxia element? That's what we did in Brussels when I did my PhD. This is a study I did together with Haibo Zhang. And what we did is we introduced tamponade. And as you can imagine, if you increase the amount of fluid in the pericardial space, you decrease cardiac output. There's no effect on saturation. There's no effect on hemoglobin. It's just global blood flow. And so when you start to decrease the cardiac output, the total delivery of oxygen decreases, but nothing much changes in your oxygen consumption. And lactate doesn't change very much. It's a little bit, but there's not a huge increase in lactate. And especially this element, the maintenance of the same oxygen consumption, basically means there's not really tissue hypoxia. It's only if you do not meet the demands of the tissues, and the demands is this consumption, because we never consume more oxygen than we need. And so this is reflecting oxygen demand. And so nothing much happens to the balance between demand and supply, mimicked by hardly an increase in lactate. But if you then further decrease cardiac output, the oxygen consumption decreases. And so the animal, despite the demand, decreases the consumption. And so basically there's a mismatch between demand and supply, which is tissue hypoxia. And then you see a significant increase in lactate. If you then remove the fluid from the pericardial space, and so basically resuscitate the animal in this case, in subsequent steps, you go the other way, basically. It's a little bit different because there's probably some hypoxia, tissue hypoxia related elements happening. But if you decrease the pericardial pressure by getting the fluid out in steps, you return to this point, lactate decreases. And if you have all the fluid removed, you're basically back at baseline. So that's basically resuscitation of tamponade. And this is what we call the critical DO2. And so basically at the critical DO2, tissue hypoxia starts. Now, critical DO2 is a whole body thing. But remember, every regional circulation has its own critical point. So the critical point for the liver is different than the critical point for the gut and the kidney and stuff. And for the brain, probably the best, the lowest. If you look at the microcirculation in obstructive shock, that's a study that we did with Michel Vergenderen, where we compared tamponade with sepsis. So in this whole change of oxygen delivery, decreasing blood flow, increasing lactate, you can see that your microcirculation decreases. And so with this study, we decreased cardiac output by infusing fluid into the pericardial space until the cardiac output was 50% of baseline. And you can see that you have a decrease in microcirculatory perfusion. If you remove the tamponade, the microcirculation returns to normal. And so making an animal fluid unresponsive, which is this phase, in tamponade, that doesn't make much sense. But this is just to illustrate that the circulation in this obstructive element, the microcirculation follows, let's say, the macro in this case. Now, how does the animal maintain the oxygen consumption despite the fact that you decrease the total amount of oxygen that you deliver because of the tamponade? That's because we use the oxygen reserve. We, let's say our arterial saturation is 100%. The mixed venous saturation, so the saturation of hemoglobin in the lung, is around 75%. And so we basically use only 25% of the total amount of oxygen available in our arterial system. And so there's a huge reserve. And so when we start to decrease the delivery, the cells remain taking up the same amount of oxygen. And so the return of blood the return blood will have less oxygen. And so your SVO2 or your SCVO2 will fall. That's what we did when we stopped treatment in a brain-dead patient, and we asked the family if we could do measurement of mixed venous saturation with a PA catheter and lactate. And this is what happened. And so we stopped the dobutamine, we stopped the mechanical ventilation. And so there was a decrease in oxygen delivery, both due to the hypoxemia, because there was no ventilation anymore, and because we stopped dobutamine, there was a decrease in cardiac output. And as you can see, gradually the central venous oxygenation drops and hardly any change in lactate. Up until this critical point, and this is very low, this is about 15%. Up until this point of 15%, there is no change in lactate. And then at this critical point, lactate start to accumulate very fast to very high levels. So basically reflecting how the human body uses the oxygen reserve before it starts to increase lactate. Now, this is almost impossible to study in critically ill patients, of course. You get the numbers, but you don't get the whole story. You don't get the context of every parameter. And so lactate is not that easy in clinical practice. But there is one very easy message with lactate. If it's increased, your patient is in trouble. If you have normal lactate, doesn't mean the patient won't die. There is no problem. Patient can go to the ward. That's not really true. But if you have lactate, the patient is in trouble. That's a study they did a long time ago in Chile, and they looked simple at patients with an increased lactate or a normal lactate. And for this, they used 2.5 as the cutoff. And as you can see, patients with a normal lactate, less than 2.5, mortality was around 8%. Whereas if they had an increased lactate, more than 2.5, almost half of the patient died. This is something completely different. This patient is something completely different than this patient. And so it's a very good warning sign, probably even better than blood pressure. This was a study from Australia, and they looked at what's the difference between having a lactate or having hypotension without lactate. And so isolated hypotension that required treatment with a vasopressor or isolated hyperlactatemia, the mortality was much higher when you had a lactate, almost twice. And so there is a very, let's say, important aspect of lactate. It tells you something is wrong and you should pay attention. Now, the other side is, what if lactate decreases? That's some time ago, Jean-Louis Vincent reviewed the literature and looked at all the studies that had at least 2 measurements of lactate, and then looked at what's the effect of changes in lactate. And in general, in almost any population, so he had general ICU, surgical, post-cardiac surgery, trauma, sepsis, cardiac arrest, respiratory failure, cardiogenic shock. If lactate decreases, that's a good sign. If lactate increases or does not improve at all, no change over time, bad sign. And so having an increased lactate is bad. If it starts to decrease, that's at least a good sign. When I was the chair of critical care in Erasmus, we did a technology assessment on lactate, and we found there is 0 studies on the use of lactate as an endpoint of resuscitation. And so we did the study. We used lactate to treat the patient, and the objective of this study was with the elements of oxygen delivery, so saturation, hemoglobin, cardiac output, and the elements of oxygen demand, so working hard to ventilate, being in pain. We manipulated this to improve the balance between demand and supply. And this was probably the first really personalized study in critical care. The p-value between the two groups was 0.06, so it seemed as if lactate was better than using standard of care, but of course, the p-value was 0.06, so the Blue Journal didn't allow us to be very optimistic in our message, but at the end of the day, 0.06 is not a meaningless intervention. And together with my friend Wang Yi in China, we did a meta-analysis of all the studies at that time available using lactate as an endpoint of resuscitation in sepsis. And this is the Jones study. Our study included every patient, but we did a subgroup analysis of the lactate study only using the sepsis. So USA, Netherlands, and 2 from China, and we found that indeed, if you adjust your therapy with the aim to decrease lactate, and all these therapies are aimed at both oxygen flow, and only ours was based on demand as well. If you do this in clinical practice, it seems that your patient probably benefits from this. So that was the evidence up until then. Now, the problem is, as you can imagine from the metabolism of lactate, there are a lot of confounders. Because if you want to use the disappearance of lactate, the changes in levels, and you want to do that with treatment of oxygen, hemoglobin, cardiac output, and giving some morphine or put the patient on a ventilator to change demand, then the clearance should not be influenced by other factors than those that you manipulate. And that's, of course, that's not the case. That's what we wrote in this paper, the 10 pitfalls of lactate clearance in sepsis. So beyond your next lactate, it is very difficult to use lactate in clinical practice because there are so many factors that influence your lactate levels. That's what we did in a clinical review, how to use lactate levels in clinical practice already some time ago. Eva Vink wrote this, and we reviewed all these factors that may influence the next level of your lactate beyond cardiac output, hemoglobin, saturation, and demand. And this is a simple demonstration of the problem. This is a diabetic patient with sepsis. And in blue, you see glucose. And as you can see, the glucose is not like crazy. The highest glucose was 11 because all these patients have, of course, insulin. And so the variation in glucose was not huge, somewhere between 5 and 11. But with every rise and fall in glucose, there was a rise and fall in lactate. And I think you would be very concerned if you see a lactate of 10 in your sepsis patient. But if this is related to a small increase in glucose metabolism, this should not need 30 ml per kilo. I mean, in the US, this is 2 liters of fluids without taking anything like this into account. So this is just a simple demonstration of the metabolic problem of lactate. And so we asked ourselves, okay, is there something different in the early phase of shock when you compare it to the later phase of shock? In other words, is the early phase where you see changes in lactate more flow related? And is the later phase more metabolism related? Without exactly trying to determine what is early and what is late, because we used a study to look at these data, and the only data we had was 0 hours, 6 hours, 12, 18, 24. So this is not to exactly determine what is early and late, but it's showing the thought that we had. So we said, we think that in the early phase of shock, and in this case, it was septic shock. And in this case, we looked at only survivors. So there is no, let's say, confounding element of severity of disease. They all survive. We said in the early phase, it's probably much more flow related. And so what we did is we looked at clearance, normalization of lactate. So this is like the INR of lactate, normalization of lactate. And this is the normalization of flow parameters. This is the delta PCO2 related to cardiac output, and this is capillary refill time, a very simple flow-related parameter. And what we found is that in the first 6 hours, the normalization of lactate, much more patients normalized their lactate very rapidly. The same with the delta PCO2. Many patients rapidly normalized their delta PCO2 and normalized their capillary refill time. But then in the period between 6 and 24 hours, the normalization of lactate was much slower, just like capillary refill time and delta PCO2. And 50% of these surviving patients still had abnormal lactate at 24 hours. And so we said, this is probably something different than this phase. And this phase is probably more flow related, where this phase is probably more related to metabolism and clearance of lactate by the metabolism. And then we did a study with Leila, with the people from the emergency room. And we looked at flow parameters and lactate levels. And so we said, okay, SCVO2 is definitely a flow parameter, delta PCO2 and capillary refill time. These are 3 flow-related parameters. So what if you have lactate with or without abnormality in these parameters? So you have a hypoperfusion context. Any of these parameters is abnormal, or all these parameters are normal. And then we looked at the differences in clinical outcome. And so they needed more norepinephrine if you had lactate plus a abnormal flow-related parameter. They needed more norepinephrine. They needed more rescue therapy. They had a higher mortality, stayed on the ICU longer and on the ventilator longer. The differences were not significant, but the signal is there. So it seemed indeed that if you have lactate with or without hypoperfusion, that's a different context. And so that's why we said, okay, then we have to compare, either use lactate or use capillary refill time. And so we did this study. We used 8 hours, 8 hours of shock resuscitation, just like in the lactate study. So we only treated for capillary refill time and lactate for only the first 8 hours, and patients needed to be included in the study within 4 hours of the diagnosis. So this is indeed very early septic shock treatment. And so we compared a study of around 400 patients. We compared the strategy using lactate or capillary refill time, and in this case, the p-value was 0.07. So basically the same problem as with lactate. In this case, JAMA didn't allow us to be somewhat optimistic. And the final product of the study was so pessimistic that the editor-in-chief of JAMA asked Derek Angus to write an editorial, which was very positive, because the clinical implication of a PO of 0.07 with capillary refill time versus lactate was, of course, very relevant. We added to this by doing a Bayesian analysis of the data. And so Bayesian is you have a primer. And so I'm very pessimistic. I think that actually if you use lactate, capillary refill time, you will start killing patients. And so with all these negative primers, even if you are extremely negative and you think that capillary refill time will actually increase mortality, the chances that the patient will benefit and so will have a decreased mortality is more than 90%. And so taking all this together, it seems that capillary refill time outperforms lactate, given the problems of lactate in let's say, perfusion, oxygenated related problems in ICU patients. And so after this study, we started the Andromeda 2 study that's currently ongoing. We skipped lactate. We don't use lactate anymore. I mean, you can in the control group, of course, but in the capillary refill time group, you're not allowed to use lactate to guide your treatment. And if capillary refill time is normal, the only interest you have is mean arterial pressure. And so no fluids, you give norepinephrine. If there is no need for fluid resuscitation, you aim for a mean arterial pressure of 60, 65. We have recruited 1,150 patients now. The endpoint is 1,500 patients. We're now doing the second interim analysis. And if the study is not stopped because of, let's say, benefit for either of the two groups, then we hope to recruit the last patient by the end of this year. And so we hope to present the data early next year. Now, what's concerning about lactate when you compare it to capillary refill time? So what if you start to create context using lactate and with or without abnormal perfusion, and you use this simple method of perfusion capillary refill time? Well, the interesting thing is this study we published a few years ago, when we looked at can you use lactate to guide your resuscitation? And of course, Surviving Sepsis campaign is very focused on a lactate of 4. And this basically indicates a lot of fluids for every patient. But if you look at the mortality and you have a normal capillary refill time with any lactate level, whether it's 2 to 4 or even when it's more than 4, there is no difference in mortality. If you have more than 4 with abnormal capillary refill time, yeah, that's really troublesome because you have an almost doubled mortality. So combining lactate with capillary refill time in this, let's say, post hoc analysis of studies seems to make a difference. So having lactate with abnormal capillary refill time is not good. That doesn't mean that you have to treat lactate with fluids. And this is a very recent study just published in Intensive Care Medicine. The typical one-size-fits-all, no reflection on mechanisms. This is just give fluids if you have an increased lactate and look at restrictive and standard. And of course, it doesn't make any difference because hyperlactatemia should not be treated with fluids. Hypoperfusion might benefit from fluids, but hyperlactatemia, of course, not. So this is it. We should abandon studies like this because this is not making much sense. And just like the lactate study, Andromeda 1 and Andromeda 2 even more, is taking the individual patient into account. It's individualized medicine. Is there a risk? So if you use capillary refill time to, let's say, create contact for your lactate, is there a risk if you don't? Yeah, and this is really troublesome. We published this a few years ago. Now look at the, this is Andromeda 1. And so we looked at patients that were in the lactate group and in the peripheral perfusion group. And if after the first 2 hours of treatment, your lactate did not decrease by 20% or normalized, you would continue resuscitation. And this resuscitation was, of course, aimed to increase oxygen delivery and blood pressure. And then we looked at abnormal capillary refill time after 2 hours in both groups. And as you can see, no difference in mortality. So if you treated peripheral perfusion, tried to improve capillary refill time and failed, if you tried to decrease lactate and you failed, and you had abnormal capillary refill, didn't make any difference. So after 2 hours of treatment, whatever you aimed in your treatment, an abnormal capillary refill time was almost associated with a 50% mortality. But this is troublesome. So in the peripheral perfusion group, if after your first 2 hours of treatment you have normal capillary refill time, and that was the end of your resuscitation. If the blood pressure was 65 or higher, stop. End of treatment. In lactate, if your lactate did not decrease by 20% or was not normal, you continue to resuscitate fluid, WTB, norepinephrine. In the patient that had normal capillary refill time in that group, so no significant change in lactate, but normal capillary refill time, you continue treatment, you almost have double mortality. And so that's a very worrisome element of treating patient basing your treatment on changes in lactate levels, and especially if capillary refill time is normal. So it seems from these two studies that I just showed you that this is more important than this. So a patient not clearing his or her increased lactate level is in trouble. There is no discussion. A patient with an abnormal peripheral perfusion, when not clearing lactate, is even in more trouble. And a patient with normal peripheral perfusion is at risk of being harmed by resuscitation efforts to correct the lactate level. And that's something that Andromeda 2 should tell you. And so the future of lactate will be diagnostic. Monitoring will relate to changing, and either increases or decreases are important messages. And lactate levels in and of itself do warrant treatment, but more thinking. What should I do? What's the message and what should I do? And read our paper on the 10 pitfalls of lactate, where we made a nice flow chart that will help you to use lactate and to manipulate oxygen delivery, tissue perfusion, in cases where lactate seems to be more related to perfusion than to metabolism. Thank you very much.
Great presentation, great talk. Can you hear me, Jan?
Yeah, I can hear you.
Oh, excellent, excellent. So all technical issues solved. Fantastic, and I'm very happy that you finished your talk with this slide, because here in the studio we have a few juniors, and I try to pass on this message to them to measure SCVO2 and PCO2 gap on a regular basis in our everyday practice. Well, do you guys have any questions? Because you do. No, Johnny, it's your turn.
Professor Bakker, thank you so much for the presentation. I have many questions. Some of them related to your previous research, and some of them related to this specific topic. Which one should I start with?
Whatever you want. The floor is yours.
So then my first question about the lactate kinetics is about the organ-specific nature of the kinetics. We talked about that different tissues are metabolizing lactate at different phases in different levels, and they have probably different kinetics. Do you see of any future research implication on these differences? Should we, as you know, we are doing clinical studies here, should we try to figure out how different tissues are reacting to lactate? And do you think there is any future in this question?
Well, that's a very interesting question that we try to answer in two different studies. The first, in both, we were focused on the liver, because we thought the liver is the problem in this case, because 80% of your lactate is metabolized by the liver back to glucose. If your liver is not functioning well, the kidney takes over a little bit, but that's about it. I mean, the amount of lactate consumed by your brain is not huge. And so the brain is not there to clear lactate. And so the first study with this was in vascular surgery, so aneurysm surgery, where you clamp the aorta. And so we put a PA catheter in the portal vein, we put a PA catheter in the hepatic vein, and we put a PA catheter in the lungs of these patients. So this was a patient with 3 PA catheters. And we measured lactate levels and the changes in lactate levels before the liver, after the liver, and in the lung, and of course in the arteries. And we found that the liver was not very relevant. There was a peak, a flush of lactate when you release the clamp in these patients. But that lactate clearly rapidly disappeared. And we found that in these patients, the lung was the major source of lactate the next morning. All these patients left to the floor. Most of them went to the floor with 3 PA catheters still in place because we were afraid to remove the portal vein catheter. And so we took it out very slowly over a day. But the patient was already on the floor. So that didn't help. Then we did a study in sheep in Chile. And we did the same. We cannulated the portal vein, the hepatic vein. We measured flow. And we found if you induce sepsis, lactate metabolism by the liver immediately goes to almost zero. While flow was not impacted. And so you had completely normal flow through the liver. The glucose, the metabolism of a sugar metabolite was completely normal, but the metabolism of lactate was absent. And so in sepsis, despite having normal liver flow, the liver starts to act very abnormal in lactate metabolism. Now, would it make sense to measure this in patients? I don't think so. It will require a huge instrumentation of the liver. And given the results that I've presented, and if Andromeda 2 is positive, lactate is probably not that important anymore as a marker of hypoperfusion. Because at the end of the day, I think it is not a marker of hypoperfusion after the first 2 or 4 hours of resuscitation anymore.
Thank you very much. Then one clinical question. We were talking about the diabetic patients and how the lactate level and glucose levels are correlating with each other heavily. Do you think that a restrictive blood glucose monitoring or blood glucose maintenance in the ICU would result in turn tightly maintained lactate level?
That's a very good question. I don't think so, because in the patient that I showed you, the variation was between 5 and 11. I mean, that would be almost a perfect, let's say, control of glucose in a clinical sepsis patient. And still, you had these huge variations in lactate levels. I think you should be aware that, especially in diabetic patients, changes in glucose can result in significant changes in lactate. And so that's why it's extremely important to create a contact. So if they call me from the emergency room, we have a patient and the lactate, and the patient is very sick, lactate is 1. I'm not in a real hurry if there are no, let's say, dramatic hypotensions and low saturation. If they call me, we have a patient with a lactate of 6, I don't need any other information. I need to be in the emergency room ASAP to have a look at the patient and see what's happening and basically creating contact. And the context is complicated by all these diseases, like hematologic diseases, where the metabolism of the tumor is relying on only glucose, and so they produce lactate in diabetes and all kinds of metabolic diseases. So lactate is not an easy parameter. The context creation by the intensivist, by the clinician, is, I think, the real challenge.
Thank you. Jan, you have a question in the Q&A. Can you please check? Have you found it?
Yeah.
So please, everyone online, I just read it out loud for those who are with us here in the studio. That the question goes to lactate levels measured can vary depending on whether caloric supplementation, i.e. continuous glucose infusion, is provided. So that is the question related to. We're looking forward to an answer.
Well, the problem is not in the supplement of glucose. The problem is in the inability to use it. And so if you have limited ability to use glucose and you give glucose, the level will go up and nothing much will happen. But if you're still able to metabolize and you rapidly start to metabolize glucose, then your lactate goes up, just like if you infuse pyruvate.
Okay, well, any other questions? I have a comment and a question. Well, first of all, how do you measure capillary refill time in your daily practice? So you go back to your ICU in New York. You are at the bedside. How do you do capillary refill time assessment?
That's a great question, and the interesting story behind it is, you all know Professor Inche, now from Erasmus in Rotterdam, and he's not a clinician. He's a technician, a physicist, and so he was in the academic medical center interested in circulation, and he rounded with the intensivist. And the first thing they did when they came to see a patient was lift the sheet and put their hand on the patient. And he said, "What are you doing?" And they said, "Well, we're checking circulation." And so if a patient is cold, that's a bad sign. And so that's how Jan became interested in microcirculation. I do exactly the same. I shake, if the patient is awake, I shake hands and I feel the legs. If the patient is sedated, I lift the sheet and I feel the legs. If the legs are warm, then capillary refill time is normal. If the legs are, I don't know, maybe cold, I'm not really sure. I do capillary refill time and I do it very simple. I press the index fingernail for 5 seconds, and then I release and do 1, 2, 3, and count how much seconds it takes. In the study, we used a glass and we used a stopwatch, and we used the other side of the finger so that you can press and actually see that the blood disappears from the microcirculation. But in clinical practice, I do it very simple. First temperature, then capillary refill time by pressing the nail bed of the index finger for 5 seconds. And of course, and that's a very important element that we got from Andromeda 1. There is bias in capillary refill time. Because if I feel a warm patient and I do capillary refill time because I'm not sure, then what can happen is I press and then 1, 2, 3. Oh yeah, that's very good. Whereas if I think it's very bad, I do 1, 2. I let's say change my counting. So there can be bias, but still, it seems that even if there is bias, that is helpful in the assessment of your patient.
Yeah, because the question I'm asking, because after a few decades of clinical work, I learned something from Jukka Takala, who is we know very well, and he's also a volunteer and a pioneer in hemodynamic research. And what I learned from him, that what he does, he just simply swipes the outside part of the toe and checks, and it's very simple, and I keep using it ever since. But that's also a very good point. Now, there is one thing I'm a little bit puzzled with, because you've been talking about mainly lactate and its relation to capillary refill and their role in hemodynamics. But what I am missing is the role of invasive hemodynamic monitoring. In other words, how to put cardiac output in this context and when?
That's an interesting question. Neither in the lactate study, nor in Andromeda 1, nor in Andromeda 2, we measure cardiac output. And I always am, I'm Dutch, so we always like to be a little bit confrontational. And I always say, who cares about cardiac output? I don't care what cardiac output is. The only question I have is cardiac output adequate?
Adequate, yeah.
And so adequacy of cardiac output doesn't need to have a cardiac output number. Now, if you measure a cardiac output and it's 1 liter, I don't need measures of adequacy anymore. Basically, if you have 1 liter of cardiac output, you look at the patient, you see there's a problem. And so the adequacy problem question is the question. And for the adequacy we use in lactate, we used SCVO2 or SVO2. And in Andromeda, you're allowed to use whatever you want. But the endpoint of the study is capillary refill time. We assume, whether that's right or wrong, but we assume that if you have normal capillary refill time, your cardiac output is adequate.
Okay, but how do you know whether to give fluid, inotropes, blood, vasopressor, or positive? You need a multimodal picture to assess that, don't you?
Yeah, that's a little bit more, let's say, challenging. Because if you want to give fluids, your patient needs to be fluid responsive. And fluid responsiveness was not tested or not structured in the lactate study, but we structured it in Andromeda 1 and in Andromeda 2. And basically, if you don't have a cardiac output monitor, non-invasive or invasive, we use stroke volume or pulse pressure variation.
Yeah. Mm-hmm.
And so if you do a passive like raising, or you give a bolus of fluids, a small bolus, and you look at changes in stroke volume or pulse pressure variation with all its limitations. Of course, it's not very extremely accurate, but in this era of not using a lot of cardiac output monitoring anymore, in the hospital in New York, where I work for another 7 days, we are not allowed to use cardiac output monitoring devices. We have no Pico, we have no Swan-Ganz. Well, we have, but it's hardly ever used. And the argument is there's never been shown that cardiac output monitoring changes mortality. So we have no cardiac output measurement other than the echo. Yeah. And so it's not even available.
Yeah, I know it's a long debate between the two sides of the Atlantic. So, yeah. Well, any other questions? Neither on the screen nor here. So, Jan, thank you very much. This was the last session of the SIP of Science this semester. So have a very nice holiday, all of you, and see you in September. And hopefully Jan Bakker will be the first to open the autumn session of the SIP of Science. So, Jan, if we not see you earlier, then see you in September. Cheers. Thanks a lot. Bye-bye. Bye.
Bye.